Hello, and welcome to the Dornsife School of Public Health's 2020 Public Health Immersion program. My name is Caroline Foyles, and I'm the Director of Student Placement and Partnership Development at Dornsife. I'm joined by Jordan Wood, the Practice Office Assistant and an undergraduate senior. Today, you'll hear from some of our faculty and alumni about how they apply public health research and practice in contributing to the well-being of local, regional, and global communities. Additionally, this module will feature examples of how Dornsife students have the opportunity to apply classroom teaching towards a world of making a difference.
Welcome to Module 2, Reproductive and Global Health. In this module, you'll hear from Dr. Suruchi Sood about her work in global reproductive health and MPH alumni Holly Cummings about her experience at Dornsife.
So I'm going to be talking about global health as part of your immersion program. Just to start off, let me give you an overview of what this presentation will cover. There are going to be 4 topics that I want to go over. What is global health? Go over brief history of global health, examine 3 key ideas in global health, and think about one innovative solution. So without further ado, let me jump right in. Let's start with what is global health. And in order to do this, let's look at what the definition of health is from the WHO. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So the definition of health really looks at prevention as a very important construct. Now, keep in mind that there is many different types of health. Of course, there is public health, which we define as the science and art of preventing disease, prolonging life, improving quality of life through organized efforts and informed choices of society, organizations, public and private communities, as well as individuals. Then we have this idea of global health. And this is the health of populations, but in a global context. And what it looks at is research and practice, but with a priority on improving health and achieving equity in health for everybody worldwide. And then we also have this notion of planetary health. And this refers to the human civilization and the state of the natural systems on which it depends. So here we are looking at broader issues, for example, issues around climate change. And finally, there is the concept of One Health. And One Health is this collaborative effort from multiple disciplines working locally, nationally, and globally to attain optimal health for people, animals, and our environment. So it's really important to keep in mind that when we talk about health, we are talking about very many different things. So the one thing to keep in mind is, so what is the difference between public, international, and global health? And what happens is that often people get very confused about international health and global health. And the important thing to keep in mind is that public health focuses on specific communities or countries, right? But global health is looking at health issues that transcend national boundaries, right? The level of cooperation required for public health is, let's say, national, but for global health, it is global. So global parties have to be involved. We are looking in terms of access, we are looking at health equity in both public health and global health. But in public health, we're looking at it within a community or within a nation. But in global health, we're looking at health equity across the entire globe. And the disciplines that we use for public health are definitely it's a very multidisciplinary field, right? But in global health, you have to not just be multidisciplinary, but you have to be interdisciplinary. So that essentially is, in short, what the difference between public, international, and global health is. So international health is really focusing on developing nations and foreign aid. So these are industrialized countries of which the US is a part, and the focus really is on how these industrialized countries can help the global south. Whereas global health is placing a priority on improving health and achieving equity for all people around the world. Now, in terms of principles of global health, it refers to any health issue that concerns many countries or is affected by transnational determinants. So, for example, climate change is a global health issue. Urbanization is a global health issue. Malnutrition, and malnutrition could be both over or undernutrition, is a global health issue. Or there are also solutions that are uniquely global in nature. So when we're looking at polio eradication, for example, that is something that needs to happen at the global level. So when we're looking at containment of pandemics, and what better example than COVID-19, right? We're looking at it from a global perspective. And how about something like approaches to tobacco control, right? So cigarettes are a global industry. And while we've done a fairly good job of ensuring that a vast majority of people who live in the US recognize what some of the negative effects of cigarettes are, across the globe that is not the case. And so approaches to tobacco control need to start looking at it from a very global perspective. And when you look at things globally, you realize that issues are very complex and there is correlation between issues of health, education, poverty, equity. It's important to think about the huge diversity that we live in. Just within Philadelphia, we have so much diversity. So when you expand that to the global level, that becomes multifold. And also respect. Respect is a big part of global health, right? Instead of looking at people and saying, why do they do that? It's really important to figure out the context that they are coming from. Now that we've talked about the definition of global health, let's go into a little bit into the history of global health. So essentially, following World War II, important steps were taken in global cooperation. And this was done by the formation of the UN and the World Bank Group. And then, of course, in 1948, when the WHO was formed. And this sort of interest in global health continued since the 1940s into, let's say, 1978, when the Alma Ata Declaration underlined the importance of primary health care. Here, now they weren't just looking at absence of removing disease or addressing disease, but actually providing primary health care. So remember that concept of health for all, right? So we were moving away from controlling infectious diseases to looking at how do you develop healthcare systems and structures so you can indeed have health for all. A couple of other trends that are important to talk about are the Millennium Development Goals. So these are 8 broad development goals that represented the major challenges facing human development, right? And these development goals were declared at a UN summit in the year 2000, and they came to be known as the MDGs. These MDGs were time bound and they provided targets, and the whole overall goal was to address extreme poverty in its many dimensions, right? So looking at poverty, hunger, disease, lack of adequate shelter, as well as exclusion. So looking at issues of gender equality in education and environment sustainability. And you'll notice that these MDGs really line up with basic human rights, right? And despite like massive commitment and global investment, progress has been far from uniform across the goal for these goals. So we had set up these goals and we had targets, and the targets were supposed to be achieved by 2015. And in some cases the targets were, but in other cases the targets weren't. And the other thing to keep in mind is that there were huge disparities across countries, but also within countries, right? And several of the MDGs were not realized. In particular, maternal health was really not according to what we had hoped. So then, building on the MDGs, we came up from 2016, we came up with this idea of what is called the Sustainable Development Goals. And the entire globe is party to these Sustainable Development Goals, including the US. And these Sustainable Development Goals started in 2016 and they go all the way to 2030. And here we have 193 countries that are all part of the UN General Assembly have adopted these goals as part of their agenda. And it's titled Transforming a World, the 2030 Agenda for Sustainable Development. So as you're thinking about global health, it's really important to think about it in terms of the Sustainable Development Goals, or the SDGs. Now, that we've talked about the history and what is global health, let's turn to the third aspect of this presentation. I want to give you or share with you three big ideas in global health. So the very first idea that I want to share with you is related to global health disparities. And what we mean here is this notion of them versus us. So when we look at health disparities, we know that there are large disparities across countries, right? So for example, life expectancy, which is an indicator of healthcare, nutrition and quality of life, varies up to 35 years around the world. An estimated 6.2 million children and adolescents under the age of 15 die, mostly from preventable causes. And more than 820 million people globally don't have enough to eat. 780 million people worldwide do not have access to safe drinking water. And every day, 10,000 people die because they lack access to affordable health care. And also important to keep in mind that the top 1% have more than twice as much wealth as 6.9 billion people. So keep in mind, almost half the world is living on less than $5.50 a day. And of course, I don't have to tell you that these disparities are much more stark, for example, when you're looking at the global south, when you're looking at low income countries, specifically in sub-Saharan Africa and in South Asia. And the whole situation is very different, let's say, when you're looking at the developed countries or the high income countries, specifically the West European countries and to some extent the US. Now keep in mind that these health disparities are not just across countries, they are also within countries. So Healthy People 2020 defines a health disparity as a particular type of health difference that is closely linked with social, economic and or environmental disadvantage. Now looking at this, we can certainly say that there are health disparities that exist in the US, right? So there are disparities that exist because of racial or ethnic groups, because of religion, because of socioeconomic status, certainly gender, age, mental health is a big issue. So disparities between how we treat mental health issues, cognitive, sensory or physical disabilities. So how we treat people with disabilities, sexual orientation, gender identity, geographic location, where you live, whether you live in an urban environment or a rural environment. And also there are historical characteristics that are linked to discrimination and exclusion, which are particularly true in the US, for example, given the history of slavery. So there is definitely a them versus us. So are those people who are the have-nots, and then there are the people who are the haves. And it's important to keep in mind that these have-nots are not somebody who's out there. Have-nots are people who are living with us within our own society. But however, let's flip this idea on its head. The idea number 2 is there a them versus us in global health? And this is important to consider when you start thinking about the globe as a whole. What are some of the common issues that we all deal with? So all of us have certain biological mechanisms, RNA, DNA, protein, and we have certain lifestyles, and we have an environment, and all of these three things interact. So our genetics interact with our lifestyle, which interacts with the environment to create health patterns. And there are 2 kinds of diseases that we need to be concerned about. The first type of diseases are communicable diseases, and these are diseases that are spread from one person through to another, and they're also known as infectious diseases. And then we have the non-communicable diseases or chronic diseases, and these are the diseases what we also call them as lifestyle diseases. So for example, cardiovascular disease and diabetes. And for the longest time, one assumes that there is a high preponderance of communicable diseases in the global south, and in the high income countries what we need to be worried about is the more chronic conditions or the non-communicable diseases. However, if we look at demographic transition across a long period of time, we will notice that what is happening is that there is a transition that is going on. And it's not new or radical. This has been going on for the last 50 years or more, ever since modern contraceptives became available, where when you started off, the population really was like a pyramid, right? So you had a lot more younger people and a lot more younger people and a lot less older people. But now what's happening is that the world is undergoing this transition. As women are practicing contraceptive use and having fewer and fewer children, we are moving into a stage where in some countries you're going to have a much higher older population, but not enough of a younger population. And this is a trend that is across the globe. This isn't something that's happening in one country and not in another. So is there a them versus us, or are we all moving in the same trajectory? Similarly, you will notice there are other positive trends. So in 1955, the average life expectancy at birth around the globe was 48 years. In 1995, it was 65 years. And we project that in 2025, average life expectancy will be 73 years. And these trends are not just trends that are happening in specific parts of a country, right? They're happening all across the globe. So you'll also notice that in 1955, 40% of all deaths were among children under 5 years. And we've made remarkable progress in addressing infant mortality, because in 2025, so 5 years from now, projections show that 8% of all deaths will be in children under 5 years of age. So we have done amazing job with primary health care around the globe. Similarly, we also notice that there is a shifting burden of disease. So when we talk about those people and us, we think about infectious diseases dominating the developing countries. And don't get me wrong, this is still the case. As the economies of these countries grow, however, non-communicable diseases become more prevalent. So this will be largely, of course, due to an adoption of Western lifestyle. So this is one of the things that we import to the whole world, and the accompanying risk factors, right? So things like smoking or high-fat diet or obesity or lack of exercise. But what's happening is that there is that shift in that burden of disease. And if you look at it over time and you're looking at the globe, you'll notice that the infectious diseases are going down, so such as tuberculosis and malaria. But at the same time, heart disease, stroke and cancers are growing up. So we are able to do things or control malaria, diarrhea, TB, HIV, AIDS. However, there are increases in cardiovascular disease, in road traffic accidents and in diabetes. So there is definitely that shift, and that shift is global in nature. What I want to do is I want to show you a really interesting video that helps you examine the entire globe and sort of makes you think about, let's not talk about this yes versus us versus them. There is no such thing as a developing country and a developed country. And there is a big movement to kind of look at it from that global perspective. So let's go ahead and watch the video. Okay, so now that you watched the video, this is one of the graphs that were in the video, and the reason I wanted to show you this figure is because the video was made several years ago, and this is the graph that has been adjusted, and this is of the latest information we have. And you will notice here that the health and income of nations, and this is data from 2015 Now, so this is life expectancy is on the y-axis and income is on the x-axis. And you will notice that for 182 nations for which data is available, you will notice that the gaps are becoming smaller and smaller. And the colors, as you know, are regions of the world, and the size of the bubbles are the size of the population. So you see the two big giants, India and China. The third idea that I want to leave you with is what happens in Vegas, unfortunately, when it comes to public health, does not stay in Vegas. And again, what better example can I give you than the COVID-19 pandemic? And what I have here are just simply two screenshots of the WHO ticker that shows you the number of cases around the globe. That's the first map, and I did this around the 10th of August 2020. And the blue map shows you the number of cases, and the red map shows you the number of deaths. And you'll notice that it is indeed a global pandemic that we are dealing with. So, coming to the last aspect of my presentation, one innovative solution. And the one thing that I want all of you to think about in your MPH program in the next 1.5 years as you go through this MPH program is this idea of thinking and being global. So the terms global and local are often used as dichotomous. But what we want to do is we want to look at a new way of looking at things, which is global. And this is that global health's traditional international focus has to be linked conceptually in practice and in research with the needs of our own domestic communities. So as applied to health and healthcare, it means simply having a global perspective or an understanding of transnational health issues, determinants and solutions that are global in nature. And it's important to then use that perspective and address healthcare priorities at the very local level. So there is a common set of transferable skills, if you will, right, which can be adapted to work with vulnerable populations wherever they might be. And these skills really, they just involve things like learning from others, adapting lessons that you've learned. It goes beyond national borders and political borders, and it really makes one believe we are part of a global planet. And so it means thinking globally and acting locally, but also globally. So, what is important is that these are some of the things that we want to think about when we're thinking about local. Large-scale change, looking at health disparities, cost-effective evidence-based solutions, partnerships, multidisciplinary teams, cultural competency, and access to healthcare. All of these things are important at the global level, but they are equally important at the local level. And so we can really combine the two. Now, as future public health practitioners, what are some of the competencies that you need to gain or you should have by the time you graduate from this program that will allow you to be truly global in nature? And these include global community engagement, right? Which is not just about a teaching tool, but also meeting the needs of a community, identifying the needs and engaging communities in solutions that are both global and that are local. So, for example, social determinants of health, international human rights law, cultural competence, all of these are larger issues, and they can be transferred regardless of whether you're working in epidemiology or whether you're in community health or prevention or whether you're in environmental health or whether you're in health policy. These are skills that you need to have as a global professional. The focus on social justice and healthcare disparities is critical, and given the sort of bi-directional learning, I think that's really important, because it's not just about because we have been to school and we have fancy degrees, we know more than people in the community do. The true way to learn things is really actually stepping out of the classroom, right? And really looking at it from that experiential level. So really, take that opportunity in the coming months and years to actually just step out of the classroom and work with people and individuals and organizations. So this way, a local program can give you more opportunities, both locally or internationally, or ideally, regardless of where you're working. It's very important to have an interprofessional approach because there's a broad array of skills, right, that are needed to improve health, right? So we have to teach students about interprofessional approaches, so at the curricular level, really. And finally, reflection. I know these few months will go by really, really quickly, more quickly than you can imagine. And I think it's also because we're on the quarter system, things tend to move very, very quickly. But I really want you to use this as an opportunity to reflect. And what we mean by this is we would like for you all to have this competency where you can enjoy structured reflective opportunities, right? Where your learning processes can be guided, and this will be important for both professional as well as your personal growth. So welcome again to the Dornsife School of Public Health at Drexel University. And I'm Suruchi Sood, and I'm an associate professor at the Department of Community Health and Prevention. And like I said, welcome to Drexel. Thank you.
Next up, we'll hear from Holly Cummings.
Hi everybody, my name is Dr. Holly Cummings. I'm an assistant professor of clinical obstetrics and gynecology at the University of Pennsylvania, and I am a proud graduate of Dornsife School of Public Health, which when I went there was simply the Drexel School of Public Health. I graduated with my MPH with a concentration of epidemiology and biostatistics in 2005. And I am really excited and honored to have been invited to share my story with you. And so what I'd like to do is share a little bit about how I got to where I am today and what it is that I do today. So I have a bachelor's of science in microbiology from the University of Maryland. And then after that, I enrolled at the School of Public Health. Chose to concentrate in epidemiology and biostatistics, and had a really great time during my public health training. The curriculum I participated in was, from what I can tell from perusing the website now, is fairly similar. I participated in a practicum project, and that was as an epidemiology intern at Pharmaceuticals, which is located right outside of Philadelphia. As part of that, I performed a comprehensive systematic literature review of the psychosocial effects of human papillomavirus infection. And this was a project related to Merck's Gardasil human papillomavirus, or HPV vaccine, which at the time was in phase 3 clinical trials. For my master's thesis, which at the time was called a CBUMP, or a community-based master's project. I think you guys now call it an ILE. I stayed on at Merck and performed a multivariate logistic regression analysis using data from their rotavirus vaccine trials. And so it was a data analysis of predictors of gastroenteritis severity in Lima, Peru. This picture here is me at our thesis poster presentation, and that's my community thesis advisor, Chris Mast, who is an epidemiologist still at Merck. After completing my MPH, I went on to complete my medical degree at the University of Louisville School of Medicine in Kentucky. It was a big decision to pursue training as a physician. It's certainly something that I thought long and hard about because I was very interested in a career in public health and really hoping to incorporate that in some way, and ultimately, decided to go to medical school. But if that's a decision any of you guys are considering, I'm happy to discuss that. I ultimately, actually, to my surprise, I would not have predicted this when I was at Drexel, but I ultimately ended up deciding to focus on a career in obstetrics and gynecology, and matched at Pennsylvania Hospital here in Philadelphia for my residency training. I then went on to be hired at the hospital at the University of Pennsylvania as an assistant professor of clinical obstetrics and gynecology with an appointment at the Perelman School of Medicine. And I am now also the course director or clerkship director for the mandatory OBGYN course that all medical students have to take. So as a physician in OBGYN, I deal with a lot of issues in sexual and reproductive health. I wanted to touch on a few of the highlights and talk about how I'm involved from a public health perspective. So, the field of obstetrics, for those of you who don't know, is prenatal care, really even preconception care, prenatal care or pregnancy care, delivery, so I deliver babies, and postpartum care, which includes caring for women with postpartum depression and supporting breastfeeding and lactation. Public health issues that are related to this are really, there's unfortunately a lot of room for improvement in a lot of these issues. We worry a lot about maternal mortality. So we know that the U.S., although we have really poor data, the data that we do have show that the U.S. has pretty dismal maternal mortality rates compared to other developed countries. And how I've sort of applied my public health interests within the field of clinical medicine is as someone who works a lot in the fields of health policy and legislative advocacy. So I'm really involved with the American College of Obstetricians and Gynecologists, or ACOG, which is our organized medicine group for OBGYNs nationally, and I'm involved at both the state and the national level. I participate in lobby days, both at the state and national level annually, and am in constant contact with my representatives to help try and shape this kind of policy, because I think it's really important. So, for instance, on the issue of maternal mortality, you guys will recognize that one of the really big issues is determining what exactly are the rates. How do we know what the maternal mortality rate is if we don't know how many women are dying related to pregnancy? So interestingly, when I first started being involved in this arena, every state has its own death certificate, and not every state included what we call a pregnancy checkbox on its death certificate. And so for the first few years that I was in practice, I was really focused on advocacy efforts to ensure that every state updated its death certificate. And so now, as of the year 2017, kind of unbelievable that it's taken that long, but as of 2017, every state has the so-called pregnancy checkbox on its death certificate. And that checkbox is literally a box that says, it's a question on the death certificate that says, was this patient pregnant within the last 42 days and the last 1 year prior to death? And so it's simply a box that the person filling out the form checks. And that helps establish the denominator of who was pregnant prior to death. The next step, what we've been working on more recently, is establishing what we call maternal mortality review committees, or MMRCs. And these are committees that meet to review those death certificates, pull out all of the people who have died and have been pregnant within 1 year prior to death, and really dig down deep and look at those cases and determine what was the cause of death. Were these things related to the antecedent pregnancy? And if so, was it, is it something that's potentially preventable? Philadelphia has had an MMRC, so Philadelphia County has had an MMRC since 2010, and a few years ago they actually published their first report. So they looked at all of the deaths in Philadelphia County between the year 2010 and 2012, 2012. And so for that 3-year period, there were 55 maternal deaths. You can read the report. It's on the Philadelphia City website, and it goes through all the different causes, everything from suicide and homicide to motor vehicle crashes to medical diseases like high blood pressure and stroke. And a certain percentage have been found to be related to the pregnancy preceding death, and some others were identified as not being related. But this is just the first step in sort of figuring out who is dying, how many people are dying, and then taking the next steps of what can we do to improve health. Pennsylvania State just established its MMRC, so Governor Wolf signed that, the establishment of a state MMRC into law as Act 24 2 years ago, and the committee has just started meeting, and so we are anxiously awaiting any data that will come from that review. So this is a really interesting place where public health intersected with medicine, so we can't perform the epidemiology work of figuring out how to prevent women from dying related to childbirth until we can figure out what the denominator is and who has died and been recently pregnant. Another aspect to pregnancy care and maternal mortality are disparities. So we know that disparities exist along racial barriers, income barriers, or racial lines, income lines, and insurance lines. And again, the more that we can do to identify what these disparities are, then we can start to take those next steps of trying to eliminate them. Another big topic these days is expanding Medicaid coverage through 1 year postpartum. So right now in Pennsylvania, if you Medicaid, as you may know, you qualify for based on income, and it is easier to qualify when you're pregnant. And so many people are able to qualify for Medicaid while they're pregnant, get their health issues taken care of, even if they're chronic health conditions, things like diabetes and high blood pressure. And then after they deliver, their insurance goes away after 60 days. And so you only have coverage for, the 40 weeks of your pregnancy plus 60 days afterwards. And so it leaves a lot of patients in the lurch, and there are definitely patients who sort of cycle on and cycle off Medicaid coverage every time they're pregnant. We know that we can improve a lot of health outcomes if we extend that coverage through 1 year after birth. And so you'll have, therefore, the support for things like high blood pressure control, diabetes control. You'll be able to allow women to access contraception more than 60 days after delivery. And all in all, it's just an excellent policy stance. There is actually a bill in the State House of State Legislature right now, sponsored by Representative Morgan Cephas of Philadelphia. And so you can look into that legislation. And I encourage you, if you think it's important, to write to your state representative and state senators in support. And then a big interest of mine is breastfeeding medicine. We know that breastfeeding, although very challenging, is ultimately a really important public health initiative, and anything that we can do to encourage women to initiate breastfeeding and then help support them in continuing breastfeeding has numerous important healthy outcomes for both the patient and for the infant. Even within the medical community, breastfeeding is sort of an area that we don't get a lot of training in as physicians, even within the fields of, say, obstetrics or pediatrics. It's just sort of something that we say, oh yeah, that's a good thing, you should do it, but we don't really know how to support people doing it. And so I work a lot with our lactation consultants in the hospital and in the community to help support patients. And one thing that I have developed is a breastfeeding medicine consult service in the hospital, so at the hospital of the University of Pennsylvania. If a patient who is breastfeeding is being taken care of by another set of physicians, so another department, and if they have any questions about how the patient's breastfeeding interacts with what else is going on in their health, they can consult our service, and physicians who have a special expertise in breastfeeding medicine are able to weigh in. So, for instance, a big thing that women hear a lot is that if they're prescribed certain medications, they need to quote unquote pump and dump and get rid of their milk. But actually, we have a lot of good data that says most medications in very common health conditions can be used safely while breastfeeding, and it's important to get that information out there. On the gynecology side, I'm also, I do full scope obstetrics and gynecology. So on the gynecology side, I see people for contraception and family planning, including preventing pregnancy, and also I perform pregnancy termination for my patients when indicated. I'm a huge proponent of vaccine efforts, including HPV vaccination, and some of that stems from my work back in my MPH days working at Merck. I perform Pap tests to screen and diagnose for cervical cancer and precancer. Pap tests, you may be aware, are one of the big breakthroughs of the 20th century at decreasing cervical cancer in this country. And so anything we can do to keep on top of that is really well worth it. Sexually transmitted infections are unfortunately very common and have the ability to be passed back and forth between sexual partners. And so we know that when one person in a sexual relationship is diagnosed with a sexually transmitted infection, it's important to treat not just that patient, but also their sexual partners. And I'll tell you a little bit in a minute about some work I do there. And then a clinical interest of mine is also working with LGBTQ patients, particularly trans men. So patients who identify as male and are seeking medical care in support of that gender identity. And so I perform gender affirmation hysterectomies to help patients achieve those gender identity goals. This is really important because people who identify as LGBTQ, and then particularly those who are trans, face a lot of discrimination historically in the medical system and have a lot of mistrust of the medical system. And so I've done a lot of work to do what I can on an individual basis with my patients to really improve their health. The big public health issues that I work on with ACOG, I mentioned the trans health. So I've done a lot of work with expedited partner treatment for sexually transmitted infections. So again, this is this concept that if you have a patient in front of you who has a positive test for an STI, we know that you need to treat their partner as well. It is a barrier to care if you then have that partner, say, okay, well, your partner needs to be treated, but they need to go to a doctor, they need to get tested, and their doctor needs to write the prescription. And instead, we can improve outcomes if we simply expedite that treatment by writing a prescription for the partner who needs to be treated. This is good medicine and good clinical care. It's a good public health policy, but unfortunately, there are real concerns that if you simply write a prescription for somebody that you haven't examined or established sort of a formal medical, doctor-patient relationship with, that you could be held liable in case of if anything were to go wrong. And so many physicians are very much reluctant to prescribe expedited partner treatment for sexually transmitted infections. And that is unfortunate because then the STIs continue to be passed back and forth between partners and among other people. And so with Pennsylvania ACOG, we have written a bill that is currently working its way through the legislature that would explicitly allow, from a legal standpoint, expedited partner treatment. And so that's something that I'm really excited about, and I hope it is able to get voted out of, it's been voted out of the state Senate Health Committee and should be headed, hopefully, to a full vote in the state Senate soon. I've done a lot of work, as I said, as well with HPV vaccination and diagnosing and treating and a lot of that stems from my early work looking at the psychosocial effects of HPV. And again, I never would have predicted 15 years ago when I was working at Merck that I would have ended up in the field of women's health and OBGYN and really doing this on a daily basis. Something that I'm not involved with directly from an organization standpoint, but I think is really cool and certainly very important for public health is our Penn Medicine Penn Votes campaign. And so Penn Votes is a campaign that's been around for a little while. This year it is linked to a national organization called Vote Plus ER, so Voter, which was an organization started out of Massachusetts that was really spread nationwide. It's very cool. It's encouraging health systems and medical professionals to sign their patients up to register to vote. It's a nonpartisan organization. And all the time I'm talking to my patients about the importance of voting and being involved from a legislative and policy perspective. And so this is really cool. We can just show this QR code to our patients and it brings them instantly to a website where they can register to vote. And in, this year in a pandemic, it's important to vote safely. And so you're able to sign up to vote by mail as well. And so that's something that I'm really proud of that, my health system is participating in. And I just think it's a really great intersection between medical care and public health. So that's me. That's what I do. I think absolutely, even though I'm a physician and traditionally medicine and public health have been considered separate fields, I think in reality, they are very much linked. And we know that individual patient health is very much linked to public health policy and public health ventures. And so it's really important to be able to have those overlap, whether it's, telling a patient without fear of repercussion that I think they should sign up to vote or wear a mask, or the fact that individually I am really grateful for my, very in-depth understanding of biostatistics and data interpretation, because that really shapes the care that I provide to patients and what I recommend they do on an individual basis. And so even though that's individual care, it's really shaped by my understanding of public health. So my, quote unquote day job and night job, since I'm delivering babies at night as well, is, OBGYN, strictly speaking. But on my off hours, I'm actively all the time promoting public health, particularly via legislative advocacy and health policy. And it's something I really enjoy doing. And I can honestly say that I would not be the physician I am today if I didn't have my public health background. So I'm very grateful for it. So that's my work in a nutshell, really quick. I am always happy to talk. That's my email address at the bottom of the screen, holly.cummings@pennmedicine.upenn.edu. Please feel free to reach out at any time if you have questions or you want to talk about a career in medicine or how to, have, medicine and public health overlap to make a satisfying career. This picture is from my graduation day, my Master in Public Health. That's me and my mom and actually my youngest sister in the background. So yeah, something I'm very proud of and very proud to have gone to. I still haven't quite been converted to calling it Dornsife School of Public Health, but very proud to be a Drexel alum. So thanks. Have a good day.
This slide highlights one of the recent Dornsife student experiences related to the topic of sexual and reproductive health. Recently, an epidemiology major in the MPH program served as a research assistant at a local hospital in the adolescent medicine clinic. This student conducted data analysis to assess trends in sexually transmitted infections in comparison to state-level data to support the clinic's understanding of how to best serve its client population. Additionally, Dornsife students have recently held placements at Access Matters, the Children's Hospital of Philadelphia, Planned Parenthood, and more. An organization that is currently accepting new volunteers is Philadelphia Fight. Thank you for viewing Module 2 of the 2020 Public Health Immersion program. As a reminder, Dornsife students who complete all 5 online modules and attend at least one of the synchronous sessions are eligible to receive a certificate of completion by completing the relevant evaluations. We welcome your feedback. The rest of these modules can be found on the Immersion program website. Stay tuned for information about our upcoming live virtual sessions that will allow students to explore these topics within the context of community-level disparities. These 3 sessions are population-focused, with panelist faculty on Black health, immigrant health, and LGBT health. We look forward to hearing about your experiences with the Immersion program at Dornsife broadly and as you continue in a career in public health.